in biostatistics in UP Diliman, and she's also the head of Joint and Bone Center in UST Hospital. So ladies and gentlemen, please welcome Dr. Julie Lee Yu.
Sorry, this is my first time joining this kind of a session. Well, like you, like her, I'm also a mom. And huwag na natin pag-usapan kung ilang taon yung babies ko. Not babies anymore, actually. Okay, so, well, we'll just go a little technical now after what you have done as an exercise. Okay, so the topic that we will be discussing is about osteoporosis. Have you heard? Everybody has heard of osteoporosis? Yes. Well, at least that's something good for us because in late 90s, around 1995 or so, okay, when we did a random survey among the general public, nobody has heard about osteoporosis. So at least we're doing something good already, and more people get to know about what osteoporosis is, hopefully. So what we need to know about osteoporosis, in layman term, we'll label this as brittle bones. Okay? So what are the facts that we have at this time? We know that we have been harping, we need to get lots of calcium in our diet, etc., etc. However, this is an actual data that we lifted from FNRI, that only 10% of Filipino households have been taking adequate calcium. I guess that's something that we have to watch out for whenever we prepare our food. And then that 9 out of 10 Filipino families have actually members who are already suffering from osteoporosis and may not be aware of it. Why is it so? Because we know that osteoporosis is a silent disease. Silent disease in that most of the time, patients will not even complain of anything. Not until the worst case scenario will be fractured. That's one thing that we are avoiding. That's why we're trying to educate more and more people about what osteoporosis is, because we want to prevent the first fracture. Okay, and then the fracture that we're after in this kind of this disease is we call it fall. It's following a fall from a standing height or standing position. So meaning, pag nadulas ka, okay, that's a fall from a standing height. And then you sustain the fracture, that's already tantamount to mean an osteoporosis-related fracture. Okay? Insufficient dietary calcium. And from 2004, despite 4-year interval, the per capita consumption of calcium as a food among Filipino households have actually decreased from 50 grams, okay, to 42 grams. So we still think that this is a significant drop. Kasi we're talking about daily consumption na yan eh. So day in, day out, we have to keep on reminding people, reminding mommies, and reminding our yayas who prepare our food to have a calcium-rich diet. Okay? In 2008, again, that's just a few years ago, only 11.5% of the households were actually adequate in calcium. We tried to compare, okay, the other forms of vitamins and minerals and see which ones kaya ang pinakamababang intake of an ordinary Filipino household. And true enough, calcium here, 11.5, only 11.5% actually meets what you call the recommended energy nutrient intake in an ordinary Filipino diet. Okay? So ito na yung pinakamababa, 11.5%. Iron is 13.5%, and then niacin, 89%, ascorbic acid, 30%. But just to focus on how much we have to work on pa in order for us to have this kind of a figure go higher. Okay? Other than looking into calcium, lagi yan, it's a pair. Calcium as well as vitamin D. It comes as a pair, lagi yan duo. Okay? So 3 out of 5 Filipinos also suffer from vitamin D deficiency. Why did we say that? Although we still are generating local data, our local data, but it seems almost all the ASEAN countries, if we're going to look at it, we are one region wherein we have rich sunlight source, right? However, despite that, there are still a lot of Asian population which we found to have vitamin D insufficiency, and worse will be vitamin D deficiency. we usually try to measure first vitamin D before we give supplementation. So we usually request for vitamin D levels, and we peg the vitamin D levels to be at least 30 nanogram per ml. So if and when people have levels lower than that, it's either they are insufficient, and worse if they are deficient. Okay? So for osteoporosis, just look at this picture. Okay? In a normal bone, okay, we call that, it's just a beehive. Parang, di ba? Beehive siya. So it's a compact bone wherein most of these struts, we call it the horizontal as well as trabecular struts, should be actually thick. In an osteoporotic bone, you just look at empty, actually. So because you have already lost a lot of your bone elements, that's why you have bones that look like this. So this is characterized in technical term, okay? This is a reduction in the bone mass with slow replacement of our bones. So when we look at our bones, we have what you call your bone-forming cells. We call that osteoblast. And then we have our bone-resorbing cells or bone-destroying cells. We call them osteoclast. In principle, for us to have a normal bone, they have to work together. So may gumagawa, may sumisira. We have to have it that way because we don't want naman too much bones because we will have, there's other genetic mutations whenever we call that too much bones. So it has a coupling. It has to be coupled together. So what happens in osteoporosis is our bone-forming cells or the osteoblast just cannot cope up with the bone-destroying cells or the osteoclasts. So the osteoclast keeps on resorbing, keeps on destroying cells wherein the bone-forming cells cannot even just catch up. Henceforth, we have a reduction in bone mass. So pag reduce ang bone mass, what happens is fracture can set in anytime. Anytime, any place in the body, provided you have the skeletal framework, kahit saan yan, it can happen. Poor bone structure leading to bone loss, strength, leads to higher risk of fracture. So which are the different sites that we are concerned of? For us women, most of the time, basta premenopausal, we are not that high risk compared to postmenopausal. Once a woman gets into menopause, because of the loss of that protective function of our estrogen, it's the estrogen that keeps our bone-forming cells active. Once we already lost our estrogen, our bone-resorbing cells, or the osteoclasts, come in. Okay? So, our focus here is, once we get into menopause, the first 15 years, once we are in the menopausal period, first 15 years is our spine. Kaya we call that vertebra. Later on in life, when we are much more older already, our next concern is our hip. Okay? Therefore, ang figure kasi niyan, the epidemiologic representation niyan is first 15 years, we look at our vertebra. Thereafter, we look at our hips. Okay? Our hands or our forearm or wrist, usually happens, nagkakaroon tayo ng tinatawag na wrist fracture or colles fracture in medical term. Colles fracture, this one is the upper arm, we usually suffer from fractures of our hand or our wrist much earlier. The reason why we have a much earlier is kasi once we are in the younger years, di ba? When we fall, our reflex is to break a fall. So how do we break a fall? Is to extend our arm. So when we extend our arm, we get more and more patients to have colles fracture in a much younger age group. In comparison to an elderly, ang older individual kasi pag madadapa yan, the reflex is not as good as when we are young. Right? So when an older individual falls, they fall on the buttocks. Pag they fall on the buttocks, ergo, we expect hip fracture to set in a much older individuals. Iba ang vertebral fracture. Vertebral fracture, you don't need to have any fall to have a vertebral fracture. I'll just tell you why. And then you have significant loss of the quality of life due to disability. So once you already have fracture, everything comes in. Para siyang vicious cycle. It doesn't only affect the individual, it also affects the family. Thereafter, it affects the society. Right? So the quality of life of the individual, of the family are actually affected. And then fracture of the hip and spine actually carries a 20% risk of death within 6 months. we don't only look at the fracture in itself, but we also look into the complications that follow. Of course, we will need to have the patient confined in the hospital. Okay. There will be period of immobility. There will be period of surgery. Thereafter, pagka-surgery, hindi naman yan agad-agad makakalakad. We should refer these patients to a physiatrist or rehabilitation medicine. However, most of these patients, dahil nga elderly, okay, they have a lot of comorbidities, right? So we look into patients who are diabetic, hypertensive, they have COPD, emphysema, asthma, etc., etc., etc. So these are other comorbidities that we look at, okay, when we talk about quality of life in a patient, okay? So all of this will contribute significantly to a high morbidity and mortality, most especially within the first 6 months that it happened, okay? So we did a survey early on, okay, in 2005, almost 10 years ago, among Filipinos surveyed in referring Metro Manila hospitals, aged 40 years and beyond, okay? These are almost 1,005 women and almost 130 men. And we only need 2 factors. It's a little simple that we can make use of kahit sa bahay or even in the clinics, that we don't have to resort to high-end procedures, very expensive procedures. So we look into, okay, this one, we call this the OSTA tool. Okay? We just look into the weight of the individual and the age of the individual. So if and when, let's say, 64-year-old female weighing, let's say, 64-year-old female weighing, let's say, 60 kilograms. So 64-year-old female weighing 60 kilograms, she should be here. Tama? So this graph, on the gray side, we call that the low-risk individuals. The green ones in the middle are medium-risk individuals. And then the ones in the red will be the high-risk individuals. What do we mean? This one will not tell us if a patient has osteoporosis or not. No. Okay. This one is just a tool to tell us which of our patients or which of the individuals are at risk. Higher probability. So if your individual is in the gray field, they are at low risk. When we say low risk, we don't intervene that much. Intervention can only include drugs, diet, exercise, right? So for low-risk individual, we focus on lifestyle risk factors. Okay? They might not need drugs. They will only need coaching. What do you need? What do you need to emphasize? Diet, exercise, modify their lifestyles. Okay? The high-risk individuals, in the absence of a central bone densitometry, which is a little expensive, okay? Pagka nalaman natin that they are already at the high-risk level, outright, we can be justified and start treatment already. And when we talk about treatment, these are drugs. These are long-term drugs that they have to be on, okay? If they're in the green bars here, or the green areas here, they are what we call the medium risk, meaning 50-50. So 50% they might be in the high risk, or 50% they might not even have the disease. So what do we suggest in patients who are at the medium risk will be get a central bone density measurement. Yung central bone density measurement, ang size niya, it's almost 3/4 of this table. It's a little bulky, henceforth we don't bring it around. Hindi yan nadadala in the supermarket, etc., etc. They're only seen in the tertiary centers, tertiary referral centers. Okay? So we make use of this, and with this kind of a tool, we were able to classify 53% of this, or 55% of this almost 1,005 women are already at high risk. 12%, okay, are at medium risk, and less than 1% are at low risk. Okay. This is just a general survey in a hospital.